Good afternoon. It is a real pleasure and a privilege to be welcoming our Bertram Pitt visiting professor. As many of our trainees know, I have no one that I respect more than Dr. Pitt at the University of Michigan. So it truly is an honor to be introducing our speaker for the day. Dr. Pitt joined the university in 1977 as the fourth chief of cardiology. He has an interesting history. He was going to go to Harvard Law School, but he decided to defer and instead went to Basel to study medicine. Then he spent time in Boston, was recruited here in 77. And by that time, he had built an amazing research portfolio in nuclear cardiology, came here, and he changed Michigan cardiology. You know, I don't think anyone in this room needs to know about his impact on the different aspects of cardiovascular care and research, but I want to just share one anecdote which may not be well known. Not only did he push for innovation, he tested some of the innovations on himself. So the first nitro patch was tested by Dr. Pitt on himself and almost put him in shock. He was involved in the innovation related to glycoprotein 2B3A, the use of lytics, but later his attention switched to the aldosterone antagonism pathway, and his work continues. So, you know, Dr. Pitt continues to surprise us with his impactful research. And in 2021, at the age of 89, he published his, I wouldn't say the last, but the last of his recent NEJM papers, which truly must be a record. And I expect that there'll be another one to follow in the next few years. So our speaker for the day is Dr. Nissen. Dr. Nissen is the Chief Academic Officer for the Heart, Vascular, and Thoracic Institute at Cleveland Clinic. He's the Lewis and Patricia Dickey Chair in Cardiovascular Medicine and Professor of Medicine at the Cleveland Clinic Lerner College of Medicine. From 2006 to 2019, he was the chair of the Department of Cardiovascular Medicine. In 2006 to 2007, he was the president of the American College of Cardiology. And he's well known as a leader of large global cardiovascular outcome trials. Many of them focused on lipid-modifying agents. He has published more than 600 journal articles, 60 book chapters. In 2007, he was selected as one of the world's 100 most influential people by Time magazine, and has been named as one of the world's most highly cited physician scientists by Thomson Reuters since 2015. So that is the official bio. So now let me tell you about my personal interaction with Dr. Nissen. So on the way here, he shared with me that when he was a medical student, he spent 8 years in Ann Arbor as an undergrad, and then he went to medical school here, and Dr. Pitt was his ICU attending. And he remembers as a medical student, Dr. Pitt, his words were torturing the residents by setting a high bar of expectation of knowledge. It was no surprise that when I was an intern at Cleveland Clinic in '96, my attending in the CCU was Dr. Nissen. And my first memory of Dr. Nissen is torturing the fellows and the residents by asking questions related to the pathophysiology, the science, and what is the knowledge base behind what we do, and what is the unanswered question, and setting a bar of excellence. And he was highly influential in me switching my career choice from going into endocrinology to cardiology. So it is a pleasure and a privilege. Please join me in warmly welcoming Steve Nissen.
Well, thank you so much for that very kind introduction. This for me is like coming home. I started my career as an undergraduate at the University of Michigan, was here for medical school, was inspired by Dr. Pitt, and I have many friends here, people that we trained, and I just can't tell you how great it's been to be back, and had a wonderful time with the fellows this morning. We spent an hour of very intense discussions that was a lot of fun for me. This is my disclosure slide. I'm going to talk about obesity and cardiovascular disease, which I think is something we all need to know more about, because I think obesity is in fact a cardiovascular disease. I do work on clinical trials with many companies, but I require them to pay any honorary speaking or consulting fees directly to a charity of their choice, so that I do not receive any income or any tax deduction. So it's like the sign in front of McDonald's, more than 100 million served. Well, obesity, more than 1 billion people are predicted to have obesity by 2030. The rate of increasing in obesity is frightening. Between 2010 and 2030, you can see where we are headed. And I can tell you, it was actually a little shocking to me. I came in yesterday afternoon, I walked out in the Diag, and 40 or 50 years ago, the young students, they are all thin, look very fit. I saw all the young people, and a fair number of them were obese. And so they will face a different life than people who are able to maintain a normal body weight. It is a global problem. It is worse in the US. We're looking at 30% obese by 2030, but Mexico, UK, you can see all the countries, and the countries like Japan and China, they're catching up. So it's everywhere. I worked very closely with Betsy McKay at the Wall Street Journal on this article, and it's about the stalling progress in cardiovascular disease. What you see here is this 1950s peak in cardiovascular disease. And, this was really bad in the 1950s and early 1960s. And then all the modern treatment came along and steadily decreased disease. But I want you to see on the right what has happened. There has been a inflection point where cardiovascular disease death is now going back up again, having reached a nadir due to contemporary therapies. The question is why? Well, Brown and Goldstein at their Nobel lecture wrote a piece. You can pull it up in Science and you can read about it. They said heart attacks gone with the century. This was 1996. That meant the year 2000. Now that they discovered the LDL receptor, and we had the 4S trial, it showed statins work, that we've got the answer. But they failed to appreciate the importance of the contemporary Western diet. And to illustrate this point, I have searched the world for the most atherogenic food. And I finally found it in Scotland. And I want to show it to you. It's a deep fried Mars bar. You can go to Scotland and you can buy one of these. You batter a Mars candy bar and then you deep fat fry it, and it comes out this nice, warm, gooey mess. You eat it and it goes straight to the left main coronary artery, and then you have an MI. So how important is obesity as a risk factor for coronary heart disease? Well, the Inner Heart study, done a few years ago, is a pretty good estimate. I think this is still accurate. You can see the effect of smoking, diabetes, hypertension, but what you also see there is a relative risk for MI of about 2.2-fold with abdominal obesity. And it ranks right up there with all of the other risk factors. Now, there's a lot of intersection of these risk factors. We're going to talk a little bit about that in a minute. But what I want you to see is that obesity is a great amplifier. So if you smoke and you have diabetes and hypertension or obesity, you have increased risk. But if you have those first three risk factors and you're obese, you have a 21-fold increased risk of a myocardial infarction. That is a big odds ratio. What about the effect on all-cause mortality? This was debated for many years. this was challenged. People said, obesity's benign. It reminds me of the term in medicine I hate the most is the term essential hypertension. I don't like that, but here's the very large UK study, 3.6 million patients followed for 11.6 years. These are non-smokers, men and women. And what you see is a nadir of mortality at a BMI of around 24 or 25. That's where you want to be. If you're thinner than that, you probably have another disease, perhaps even cancer. But as you go up in body weight, there is a graded response with an increased risk of mortality. You can see that it takes time. Obesity is something that over decades accumulates risk. And here you can see going from underweight to normal weight to obese to morbidly obese, what happens to the lifetime risk of cardiovascular disease. And 20, 25 years into obesity, you're starting to see a huge acceleration in the incidence of cardiovascular morbidity and mortality. This happens to be men, looks the same for women. What does it cost in terms of life expectancy? Well, if you're morbidly obese, we're talking about 8 to 9 years of life expectancy. It's a lot. But even if you're moderately obese, you're losing years of life expectancy. That's what the data show. So how does obesity relate to cardiovascular disease? Well, it is an unusual risk factor in that it affects everything. Heart failure, very dramatic. Coronary disease, stroke. And as I'll show you, there's more yet. And each step as you go up the pathway from normal to overweight to obese to severe obesity, it gets worse. So it is truly a risk factor that crosses the many boundaries of weight. One of the most dramatic effects is on heart failure. And of course, one of the questions we're going to talk about is why. But look at the rates of heart failure in Framingham in people that were overweight and obese compared to people of normal weight. And again, this is from of 10 to 15 years out. You can see these increases, these cumulative incidence of heart failure is really high if you're obese. It's also a very strong risk factor for new onset atrial fibrillation. Question is why? If you're obese, much more likely, whether you're a man or a woman, to have a new onset of atrial fibrillation. So all of the things, almost all the things that we treat are affected by obesity. All these subspecialties of cardiology, EP, heart failure, coronary disease. Now, one of the things we're seeing now is an epidemic of childhood obesity. And childhood obesity is a really huge problem. It's in many ways, if you have obesity as a child and you remain obese as an adult, you have a high incidence of type 2 diabetes, hypertension, low HDL, and hypertriglyceridemia. If you're obese only as a child, the risks are much more modest. And so that tells us where interventions are necessary. We want to get to people. Those young students that I saw last night, you want to stop them and say, look, your life is going to be altered in a major way because you're already obese and you're only 19 years old. And so it's really important to understand that we've got to deal with this disorder earlier in life. Now, one of the questions that comes up is, can fitness reduce or eliminate the adverse cardiovascular outcomes associated with obesity? Some people say, yeah, I'm overweight, but I'm really fit. So let me show you the data. So this is 1 million Swedish military conscripts, and you see deciles of cardiorespiratory fitness. If you look at the cumulative incidence of cardiovascular disease, if you're in that top decile for, in this case, reduced fitness, very bad long-term outcomes. Body mass index as well. So million Swedish military recruits, if you're 16 and 19 years old and you're overweight, look at the trajectory that you're on for outcomes. Now, what if you're fit? Well, you see on the left, fit men who are obese still have a 39% increased risk of CVD. If you're unfit, it's worse. But fitness doesn't eliminate the effect of obesity. It just attenuates it. On the right, you see the same thing for women. What's really bad is obese, unfit women really takes a toll. And there is a disproportionate toll in many ways of obesity on women compared with men, a topic maybe for another day. We also hear people talk about, well, what if you're obese, but you're metabolically healthy? You don't have any of the metabolic center. You don't have a hypertriglyceridemia, you don't have hypertension or any of those things. And what you see is, yes, it's true that metabolically healthy obese patients do better than metabolically unhealthy. It happens to be relatively uncommon to be metabolically healthy, but if you are, you still have an increased risk. So you don't make the risk go away by being metabolically healthy. So the question then is, how does obesity cause cardiovascular disease? Not such a simple question. Many of us believe that the common soil is insulin resistance. If you are obese, particularly as I'll show you, if you're abdominally obese, you are insulin resistant. And all of the things in that center column are affected by insulin resistance. Hypertension, hyperinsulinemia, diabetes, hypertriglyceridemia, and so on, hypercoagulability. And on the right, the end result is atherosclerosis. So this is the common pathway, I think, that leads to all of this. The other thing that happens is you have ectopic fat distribution. People who are obese don't just have a big belly. They have fat in the liver, in the myocardium, in the pericardium, and in the renal sinus. So the reason that all these other things are affected is the ectopic fat distribution in obesity is far more than the eye can see. It affects most of the organ systems, and I'll show you a little bit about that in a minute. One of the things that I wanted to show you is that the disease of the 21st century is non-alcoholic fatty liver disease. It is an epidemic, and this is what it looks like on biopsy. Those big globules are fat accumulating in the liver, strongly associated with obesity, and it leads, as I will show you, to non-alcoholic steatohepatitis, NASH. So non-alcoholic fatty liver disease is the stage 1, but stages 2 and 3 are a whole lot worse. And so we have to think about our patients, and Stan Cicutti or somebody told me, maybe it was Gurm, that the mean BMI of patients coming to catheterization now here is 30. Those are the patients that are in your cath lab. These are our patients. These are the people we're treating. And they have all these things. They have visceral adiposity, insulin resistance, they have dyslipidemia, hypertension, and very importantly, they have increased inflammation. there is a very close link between obesity and elevated C-reactive protein. And I hope you understand that atherosclerosis in many ways is an inflammatory disorder, as Russell Ross predicted a long, long time ago. This issue of non-alcoholic fatty liver disease, let me show you that it is now rivaling alcoholic liver disease for the cause for liver transplantation. The wait list for liver transplantation now is filled with patients that have fatty liver disease, that have NASH. Hepatitis C as a cause for liver transplantation is going away now that we have treatment. But NASH is increasing, and unfortunately, so is alcoholic liver disease. Now, Elliot Jocelyn was a pretty smart guy, founded the Jocelyn Clinic. And in 1927, he said this: with an excess of fat, diabetes begins, and from an excess of fat, diabetics die. Wow. Well, you know, this is preaching to the choir, but the relationship between body mass index and the relative risk of type 2 diabetes is extraordinary. Look at the risk for a BMI of 22 or 23 on the left, and look at the risk for somebody with a BMI of 35. So this epidemic of diabetes, clearly, if we could avoid obesity, we would avoid the type 2 diabetes epidemic. It is not just obesity that's involved. It is abdominal obesity. And the intra-abdominal fat is much more metabolically active. It produces cytokines, which go to the liver, which make inflammatory, we make IL-6, CRP, and there's this intersection. Elevated CRP, elevated CVD risk, yes, obesity, but really at the center is abdominal obesity. And what's going on here is there is the release on the right of these adipokines produced by the fat cells. Fat cells are not just inert. They're incredibly active, producing these adipokines, which end up in the liver, in the epicardium, and in muscle, and they alter the patient's metabolic profile. So abdominal obesity leads to cytokines, which lead to downstream effects. Let me show you why we ought to be measuring waist circumference and not just BMI. I don't know if you guys do this in your clinics or not, but you should. Take somebody with a body mass index of 30. They can have a waist circumference of 88, or they can have a waist circumference of almost 110. And those patients have a different outcome. So it's really the abdominal fat that's so toxic to cardiovascular health, and you cannot exactly predict that if you know the BMI. And so we talk about people who are apple-shaped versus pear-shaped. You see some women who have the gynecoid, pattern obesity, where there's a lot of fat in the buttocks and in the thighs, and they tend to be more metabolically healthy than a man who comes in with a big tummy bulge. Those are the people that are developing cardiovascular disease. And I want to show you why that is true. Here is people in the lowest tertile of BMI. Look at the left. And then look what happens if you have a low BMI, but a high waist circumference. Almost a twofold increase in hazard ratio for cardiovascular disease. Yes, it's true. On the right tertile, BMIs that are greater than 28, same effect. But you can have a low BMI, but if you have a high waist circumference, you have a much higher risk of developing cardiovascular disease. And here's something that everybody here should know. This is ethically different. So this is the glycemic effect of BMI. what you see here is that a BMI of 22.6 in a South Asian, someone from India, has the same effect as a BMI of 30 in white Europeans. What's going on here is, and we see this all the time, we see somebody of Indian ancestry who comes in and you look at them and they don't look obese. They have just a little bit of a bulge in their tummy and their HDL is 28 and they have all of the effects of obesity, but their BMI is not high. They just have a little bit of abdominal obesity. And so we have to be sensitive to the ethnic differences in this disorder. One of the things that happens with obesity, we've known this for 30 years, is that the higher your BMI, the higher your C-reactive protein. And I happen to be a big believer in the effect of inflammation on cardiovascular disease, but it's being driven by obesity. It's being driven by the intra-abdominal fat, leading to the cytokines, leading to all the effects on inflammation. So the question is, can weight loss favorably affect these risk factors? Well, here's what we know. We've known this for quite some time, that these are, if you see in the gold boxes are the surgical trials, and you see that with a mean body weight decrease that's fairly substantial, there is a very large reduction in C-reactive protein. It's less striking from this older study with medical treatments because the medical treatments weren't very good at the time. But there's no reason to believe that medically reducing body weight won't also have the same effect. And we know, in fact, now that it does. What about the effect of weight loss on diabetes? So a number of years ago, our bariatric surgeons came to me, and they'd never done a clinical trial. There's not a lot of surgical, randomized trials. And they said, we want to study the effect of bariatric surgery on people with established diabetes to see if we can make their diabetes go away with bariatric surgery. So we did that. This is the trial published in the New England Journal of Medicine. It's the only trial I ever did. We published the 1-year results in the New England Journal, the 3-year results in the New England Journal, and the 5-year results in the New England Journal. This happens to be the 3-year paper. And here's what the study did. There's only 150 patients. Elevated BMI, intensive medical therapy with what we had in those days versus a Roux-en-Y gastric bypass versus a sleeve gastrectomy. And we had 50 patients in each of these cohorts. And we followed them long-term for up to 60 months of follow-up, but we published the initial results after just a year. This is also a lesson for those of you that want to do. Clinical trials don't have to be enormous to be impactful. They can be modest and be impactful. This one was, because here's what happened. We did reduce BMI with gastric bypass by about 25%, a little bit less with sleeve gastrectomy, and it was maintained over the first 3 years with a slight increase over time, compared with very good medical therapy, the best we could offer. And this was what happened to hemoglobin A1C. It plummeted. And many of these patients were on insulin. They came off insulin. They came off their drugs. Many of them ended up on metformin alone. They had almost a 3% reduction in HbA1c. 3%. If you were 9%, you went down to 6%. Incredible what weight loss could do. This is the number of diabetes medications. They were on an average of 2.6 meds, and they ended up with gastric bypass on an average of 0.5 meds, less than one medication for their diabetes. And here's what happened to this is kind of the sort of the big picture. BMI went down 8 to 9 points. A1C went down 2.5 to 3%. HDL went up by about 15. Triglycerides dropped by a lot, and CRP went down enormously. So there you have it. Not only is, as Jocelyn said, diabetics, that fat is the enemy. If you can make the fat go away, you can make the diabetes go away. It's a very important insight. We did that with a 150 patient trial. It was a lot of fun to do that with our bariatric surgery. But what about diet or drug therapy? Can we do as well with diet or drug therapy? So the NIH had this great idea. They spent $100 million. It's a lot for the NIH to spend. 16 centers, 5,000 patients with type 2 diabetes who were randomized to intensive caloric reduction and increased physical activity. They had coaches. They saw these people constantly, and they kept working with them on lifestyle changes to get them to lose weight and become better. The primary outcome was CV death, non-fatal M, non-fatal stroke, or hospitalization for angina. They had a maximum follow-up of 13.5 years. Can't do this with industry. They don't have that much patent life. Median of 9.6 years. This was, and only less than 4% lost to follow-up. High quality, long-term study of diet and exercise. And they did, in fact, get them to lose a little bit of weight, but not for long. The mean effect over 10 years was 4 kilograms. That was the time average reduction in body weight. And probably shouldn't be a surprise. The effect on the primary cardiovascular endpoint was about as neutral as you can get. I mean, those curves are superimposable. It didn't work. I wished it had. I wished I could tell you that you could counsel your patients, you can see them frequently, you can tell them, you can have them see a nutritionist, you can do all those things, and you can make them healthy from obesity. This disease is refractory. It's really hard to treat with diet and lifestyle. So drugs were developed, and it is the saddest history you can imagine. And I was involved in a number of these. I did the rimonabant study. I did the bupropion, naltrexone study. Amphetamines, high abuse potential. Fenfluramine, oh God, what a story. You know, fatal pulmonary hypertension, and the fen-phen, terrible valvular heart disease. I know you saw a lot of that here. I certainly saw it. Sibutramine was a disaster. It was withdrawn for increased cardiovascular morbidity and mortality. Orlistat, hate to even talk about it, you know, anal leakage, not too pleasant. Rimonabant, I did one of the rimonabant studies. It was withdrawn from development because of suicide. Lorcaserin was withdrawn because of malignancy. And I did the bupropion naltrexone study, and that, you can read that JAMA paper, that was an absolute disaster. So, the established benefits of weight loss drugs on clinically important cardiovascular outcomes. The slide is intentionally left blank. Until just a few weeks ago, no drug therapy, no diet, no plan had an effect. You know, all these drugs to treat LDL cholesterol, we got PCSK9 inhibitors, we have great antihypertensive drugs, but we can't, the driver of so much of the disease, we have no treatment for yet, but it's coming. So in the absence of established outcome benefits, there are only risks and costs. That's all we have. Well, we decided to study what we knew we could do, which is to take the really obese patients and do bariatric surgery. So we took patients with diabetes and we asked the question, can we favorably affect cardiovascular outcomes? And so my colleague Aaliyah Minion and I did a series of studies. They're published in JAMA, which was to look at the association of surgery with major adverse cardiovascular outcomes. Now, what we did is it's an inverse probability weighted observational study. It's doubly robust, includes Cox proportional hazard modeling. It's as good an observational study as we knew how to do. And here's what happened. Not surprisingly, they lost weight, and not surprisingly, they had an improvement in their HbA1c. But what was stunning about this large study was we had a 6-component MACE outcome. I won't go through all the components, but it's the 3 typical death, stroke, MI plus others. The hazard ratio was 0.61. You know, you don't get hazard ratios like that every day. I know it's an observational study, but look at what happens. Look at how quickly the Kaplan-Meier curves separate. If you just take hard endpoints, death, stroke, myocardial infarction, the hazard ratio is 0.62. P-value is less than 0.001. You take the body weight away, and you have an enormous reduction in cardiovascular morbidity, mortality. Let me show you a couple of the components. All-cause mortality. All-cause mortality, hazard ratio 0.59. Early separation of the curves. And the most stunning of all was heart failure. The hazard ratio is 0.38. I hope there's some of our heart failure faculty here today. 0.38. P-value less than 0.001. Now, look, it's an observational study. And I'd be the first to tell you that observational studies are not definitive. But it taught us that if we can find ways to get patients to lose weight, we can have an enormous impact on the morbidity and mortality from cardiovascular disease. What about fatty liver disease? Well, fatty liver disease progresses from A, fatty liver, to B is NASH, to C is cirrhosis, and D ain't on here. D is liver transplantation. That's what happens to people, and there are a lot of them out there. So I showed you this, and let me show you what we found. This is the hazard ratio for major adverse liver outcomes. It's essentially liver death or cirrhosis with bariatric surgery. Now, Kim, you guys have been looking at clinical trials for many decades. When was the last time you saw a hazard ratio of 0.12? This is what happened to progression of liver disease when we got people to lose weight with bariatric surgery. Again, it's an observational study, but it is, in my view, I don't think it can be wrong. Maybe we overestimated the treatment effect, but it's incredible how much impact we have. The fat that people have is distributed everywhere: liver, kidney, heart, and they're all affected by it. So what about newer pharmacological therapies? Finally, after all these years, we got some better treatments. So can they offer the weight loss that's provided by bariatric surgery? Well, the answer is yes. The first of these to really show a big effect was semaglutide. And the effect was on the 2.4 milligram dose. And some of you I know are prescribing these drugs, which I was happy to hear from Eric Brandt that he's prescribing these drugs. But you can see that people lost about 10% of body weight over 68 weeks. Published in The Lancet, pretty good. We've been interested in the incretin system. There are 3 components, and we'll talk about them in a minute. But we wanted to find out if we could have agonists for more than just GLP-1. We could have agonists for GIP and for glucagon. Those are the 3 components of this system. So GLP-1, GIP, which is glucose-dependent insulinotropic peptide, polypeptide, and glucagon receptors. And the designers of drugs can build peptides that are multifunctional. And there has been a series of developments on attacking the incretin system as a way to get, and we think maybe bariatric surgery in part works because of its effect on the incretin system. That's another day, another talk. So here's how it works. You build a peptide, and you can build a balanced hybrid that affects all three incretins. You can go do an imbalanced hybrid that has greater effects on one versus the other. You can create these synthetically, and you can control how much effect you have on each of the incretins. So tirzepatide was the first dual, and it's a GIP GLP-1 agonist. It's a multifunctional peptide, but it's much higher potency for GIP and less potent for GLP. It's got a half-life of 5 days, so you can give it once a week. And the drug, of course, was introduced fairly recently for treatment of diabetes. But just last year, this SURMOUNT-1 trial was published. It was a 72-week trial, so a year and a half. And the median body weight at the full dosage, this was a dose-finding study, was 22.5%. If you go back and you look at my earlier slides, that's about what we get with bariatric surgery. So now here's a drug that can produce weight loss that's the same, almost the same as bariatric surgery. What about triple agonists? What if you create a three-function peptide? Well, they did it. And if you read the New England Journal, you know that just a few months ago, this study with retatrutide was published. It's a GIP, GLP, glucagon receptor agonist. It's most potent at GIP, but it has effects on all three. Again, it's got a long half-life, so it's a once a week, and it was studied in a 48-week phase 2 trial. I want to show you the results because it's just an incredible development. And there's more coming. There's more of these drugs coming. You need to know about them, and you ought to be willing to prescribe them, not leave it to the endocrinologist. But it's our disease. Obesity is a cardiovascular disease, and we need to be the ones that treat it. Half female, BMI of 37, plenty of those people around. They could not have diabetes. They could only be pre-diabetic. The median weight loss at 48 weeks was 24.2%. Almost 1/4 of body weight was lost at the full dose. But let me show you what happened in specific subgroups. If your BMI was over 35, the median weight loss was 26.5% with the triple agonist. All three incretin systems were affected. And if you were female, the median weight loss was 28.5%. I never thought in my lifetime I'd see a way to treat obesity with this degree of efficacy. It's coming. It's not approved. It's still investigational, but it's exciting. And, obviously it needs to be studied further. What about oral agonists? Well, these very clever chemists have come up with an oral incretin-based therapy. And if you read the New England Journal, orforglipron, hard to pronounce, it's a non-peptide GLP-1 agonist, once daily, was developed for diabetes and obesity. It's got a long half-life to be given once a day. And New England Journal manuscript recently published, there was a 15% weight loss, not with an injectable, but with an oral GLP-1 agonist. We want to see more, still in development, but I'm showing you where the future is going to go for us to be able to treat the obesity epidemic. Now, can these newer therapies reduce morbidity and mortality. Well, something exciting is about to happen. For those of you going to the AHA, you're going to get to see it. It was announced by Novo Nordisk that they had a 20% reduction in morbidity and mortality. The endpoint was death stroke MI with semaglutide 2.4 milligrams. It will be presented 17,600 patients. It will be presented by my colleague, Dr. Mike Linkoff, at the opening ceremony of the AHA this year. And I'm anxiously awaiting seeing the results, subgroups, which endpoints were most affected. You understand that my slide that showed that blank is about to change, because now we know that an incretin-based therapy can not only reduce body weight, can not only reduce blood sugar, but can reduce morbidity and mortality. And it's coming this fall at the AHA. Now, let me just finish by telling you that my team at C5 Research, we have 100 people that work with me in organizing clinical trials. We're doing one with tirzepatide, the dual incretin. And we're studying both primary and secondary prevention patients. The semaglutide study was only secondary prevention. I want to study primary prevention because I want to treat people before they're sick, before they have cardiovascular disease. So we have a very large study, 15,000 patients. We're probably going to make it bigger. It's enrolling like crazy right now. It's got primary and secondary prevention patients, and we're addressing this issue. BMI of 27 or greater. The primary prevention patients have to have 3 risk factors, and they have to be a little bit older, but they've never had a cardiovascular event. And then the secondary prevention patients are classic secondary prevention. So we're going to take on this primary and secondary prevention question. The primary endpoint is time to first occurrence of all-cause mortality, non-fatal MI, non-fatal stroke, coronary revascularization, or heart failure events that require hospitalization. We're not just going to look at death stroke MI. We're going to look at broader endpoints. And we have secondary endpoint of atrial fibrillation, of renal outcomes. We're going to tell you what happens with a drug that leads to 20+% weight loss in patients without diabetes. What happens to all of these endpoints that are affected by ectopic fat, kidney. We have a liver endpoint as well. It's not the primary, but we'll give you that data when this study is done in a few years. So let me summarize, and I deliberately left a few minutes to have questions. Obesity increases many heart disease forms: coronary disease, heart failure, stroke, AF, and all-cause mortality. It is abdominal obesity, waist circumference, that is more closely linked to adverse outcomes in BMI, even in physically fit and metabolically healthy obese patients. The mechanisms of harm are multiple. They include glucose intolerance, hypertension, inflammation, increased triglycerides, and a low HDL. We now know that substantial weight loss with bariatric surgery is linked to reduced cardiovascular risk, but we now can potentially achieve this with pharmacological therapies. Colleagues, this epidemic, this incredibly bad public health epidemic of obesity, we are on the verge of having the tools we need to win the battle. I want cardiologists, because it's a cardiovascular disease, to be involved in leading the way. And so the trial I'm doing, the sites that are enrolling patients are cardiovascular sites. This is our disease. We need to learn how to treat it. Thank you very much for your attention.
Nissen, that was a phenomenal presentation. Thank you very much for your time and for all that knowledge. I'm going to open with a question, and then we'll have the audience bring the rest. But I want to touch a little bit on what you mentioned at the end. where do you see the cardiologists? I think you said at the forefront. But
Yeah.
how do you see the cardiologists taking the lead in treating? Do you see them as a kind of leading the prevention, leading the management of obese patients with complex cardiovascular disease?
I was so pleased. I met with Eric Brandt in your prevention group, who's primarily now research, but he sees patients. And he told me that he, in his prevention clinic, is regularly prescribing GLP-1 agonists for weight loss to patients without diabetes. And look, given the fact that the disease has such profound implications for heart disease, I think we should take the lead. These are easy medications to prescribe. You just have to get your head around it and say, okay, I'm going to learn a little bit about this and I'm going to start prescribing it. And, yes, probably the endocrinologists are going to play a big role in the use of these drugs for diabetes, but I think we can play a big role in using these drugs to treat obesity in patients with cardiovascular disease. And that's what I want us to do.
Steve, I really enjoyed your talk. And thanks for your remarkable leadership of frontiers in cardiovascular science over the years. And having you deliver the Pitt lecture is only fitting, as you're a Michigan guy from the beginning. And Bert has been sort of a living legend here for a long time. I have two questions. One is, if you're in clinic and choosing between GLP-1 agents for a given patient, how do you make that choice, or is it mainly insurance?
Yeah.
And the second is, if there's one side effect that keeps you up at night that you worry about, what is it?
Yeah. Well, first of all, the drugs are well tolerated. If you read the New York Times, you'll know there was an article that suggested that there are people that have permanent GI dysfunction. I don't think that's right, because I've really looked at the databases and the trials. I think they have another disease, and it's true and unrelated. So I do think these drugs are very well tolerated. People do not get hypoglycemic, even those that don't. You can come in and you can be obese and you can have a hemoglobin A1C of 5.5%, and you get a GLP-1 agonist and you don't have hypoglycemia because they only work when your glucose is elevated. So that's, on glucose. So I'm really pretty comfortable that these drugs are very, very safe. Now, how do you choose one over the other? Well, they are different. I was involved with liraglutide. Liraglutide produces pretty modest weight loss. I don't think it's very effective for this purpose. Dulaglutide is intermediate, and semaglutide in the full high dose seems to be the most effective. But now we have another horse here, which is to run, which is tirzepatide, which is another step beyond semaglutide. So if I really want to treat weight as opposed to diabetes, then my preference would be for tirzepatide, because it's such an effective weight loss drug.
I have a question from the virtual audience. Ahmed Abdelatif says, great talk. The link between obesity and inflammation is compelling. How can we explain the modest benefit of anti-inflammatory drugs in clinical studies?
Anti-inflammatory. Well, it's not modest. Okay, if you keep your eye on this ball, because the FDA just recently approved colchicine for cardiovascular benefit. You should read the two studies that have been done. They're not perfect, but there was a very large reduction in morbidity and mortality with colchicine. And I was involved with Paul Ridker in the design of the CANTOS trial, and there was a nice benefit with canakinumab. The problem was it wasn't a practical approach that could be developed. The company didn't want to move it forward, but we now have pure anti-inflammatory drugs with no effect on lipids that have shown a reduction in morbidity and mortality. I'd rather reduce inflammation by reducing body weight but you can also do it with drugs. And by the way, our bempedoic acid study, which we reported earlier this year, the anti-inflammatory effect was probably playing a pretty big role in the fact that we got a benefit from very modest LDL reduction.
A couple of questions. First one is there any data for weight gain due to neuroleptics with the GLP agonists? Are they effective?
Oh, yeah, that's a good question. I don't know any data. It's actually a big problem, and I think it's something that somebody should study, and maybe you. But I think this is an example. This is just a door opening here. This is the first time historically we've actually been able to treat the disease. Now we got to figure out who to treat and under what circumstances. And that's a population I don't know that they've been studied. They should be.
And then what about reports of loss of muscle density with these drugs?
Anytime you lose weight, if you're not careful, you lose muscle mass. So what we should do with our patients as they lose weight, they have to do both aerobic and muscle strengthening exercises, because otherwise when you lose weight, you not just lose fat, you also lose muscle. And you can successfully navigate this if you work closely with your patient.
Thank you for a wonderful talk. My question is, from a clinical aspect, studies show that when you discontinue these medications, that their weight rebounds.
Yeah.
What do you envision in the future, especially given the rapid effect, but the high, even short-term cost?
Yeah.
How we can get patients off and maintain?
So you're right, but I'm going to give you an analogy. Okay. If you have somebody that comes to see you with heterozygous FH, and you give them a statin and ezetimibe, and their LDL goes down, you're giving them a lifelong therapy. If you take the statin and ezetimibe away, their LDL goes back up. If you have a hypertension patient, you treat their hypertension, you lower their blood pressure. If you take the drug away, their blood pressure goes back up. This is the same thing. It's just a different disease. And so I think we have to recognize that it will be required lifelong therapy. Now, look, these drugs are costly, but their patent life isn't going to be forever. And those younger faculty in the audience here are going to have the opportunity to give generic, incretin-based therapies in a few years. I don't know when semaglutide goes off patent, but it's been around for a while. It may be maybe 5 years, 6 years, 7 years. And then we are going to be able to offer relatively less costly therapies. I am troubled by the cost of these drugs. I can't get some of my patients on them. And some of them, you can only get them on the drugs if their BMI is 35 or greater. So we're going to have to live with that for a while.
Thank you so much. My name is George Han. I'm one of the interventional structural fellows. Just a question about seeing the benefit of surgery and then seeing how all these new pharmaceutical agents are very promising. Is there a role of combined versus investigating surgery versus these new medications now that these are likely going to be the new medical management? Yeah.
So given the fact that the most effective surgery, which is a Roux-en-Y gastric bypass, is a pretty big rerouting of your, GI system, and can be reversed, but it's a big deal. And I didn't show you the long-term adverse effects in our studies of bariatric surgery, but they're quite substantial. I think it's like everything that happens in medicine. We transition from the most invasive to the least invasive therapy for a disorder that we treat. We went from surgical aortic valve replacement to transcatheter aortic valve replacement. And I think it's the same story. Look, on my large trial of tirzepatide for obesity, my bariatric surgical colleague, Ali Minion, is on the I put him on the executive committee. And what he'll say to you is, I hope you can put me out of business. He'll find another thing to do. And that's a great perspective for a surgeon to have.
All right, we are on time. Dr. Nissen, again, thank you so much for your time and your lecture.